CT, and then they will see nothing on rapid, and they will say, what is the problem? This is a false negative. So this is actually something I just spend a little bit of time on. So remember that this is the measure of core is a surrogate measure. It's not DWI. So here's a patient who came in and they're a good candidate, and then the clot disappeared. It reperfused in this case. And then you scan them later. And then you see they have obviously a new stroke. Actually, it was predicted by rapid very well. Here's the stroke, the core. But then you look at the CBF less than 30% and you say, wait, why is there no core? Why is this missing? Why isn't there pink here? The reason is very simple. It's because if you remove the clot, blood flow is now normal everywhere, including through the dead tissue. It's not true that when tissue dies, all the blood flow just stops. So that's why you may see this pattern. It seems confusing, but it's really not. And the simplest thing, the simplest rule is that whenever you see something on non-contrast head CT, doesn't matter what perfusion says. This is it. That's dead. You're done. Finished. Okay. Then another example that's a little more tricky is, so here's a patient who, again, is very similar, okay, but their clot was never pulled, and you see they're getting worse and worse and worse. And then, you know, at hour 24, they have this big delay, it's still there. They have a huge stroke here. But then again, you see CBF less than 30% is normal. And then you say, what? This is ridiculous because rapid is not working. Why? What's going on? So what's happening here is another blood flow phenomenon, because what happens is late in the course of stroke, you can get increased recruitment of collateral. So the clot is still there, but these leptomeningeal collaterals have bumped the blood flow up just above 30%. And that's why you don't see anything on this map. It disappears, okay? But obviously, the non-con head CT shows a stroke. In fact, if you did the non-con head CT, you wouldn't even do perfusion, you'd just stop. Okay, so you may see this sometimes where you see an obvious stroke, an old or a new one, and then less than 30% you see nothing, and you're like, oh, rapid's not working, what's happening? But it's just because of these strange blood flow phenomena. And the simple rule is whenever you see this, doesn't matter about this, just go with your non-contrast head CT. So that's really important, because people in the United States, some sites are fine, but some people got really confused about that. So that's important. Does that make sense? Yeah. Okay. Yeah. So always go with your non-contrast head CT. Sometimes it won't match, and that just has to do with different forms of blood flow changes that happen early or late in stroke. But you can always look at your non-con head CT, and that will tell you what you need to know. Any questions about that? Yes. Yeah. So why do we do this? Yes. So yes, you wouldn't normally do this. This is just experimental. But what this is meant, this is a very good question. What this is meant to show you is, let's say you had a patient and they were like this at home, you know, and they're coming to the hospital in an hour, and then spontaneously the clot dissolves, like from AFib, it just disappears. So you don't actually do this scan. This is your first scan. And then you see, you don't even know about this. So yeah, you would never do this in real life. But let's say they have a clot at home. Yeah, then this is your first scan. And then you look at this and you're like, what? This is obviously a new stroke. Why isn't it here? That's why I show you. Yeah. And same thing here, you know, you wouldn't be doing this and this and this, but this again, if you have this is your first scan, and you say, look, they have a huge stroke, what's happening? And then there's nothing here, that's what's going on. Yeah. Yeah, very good question. Good. Okay, good. But we definitely have sites who complain about that, and they don't really understand that, so that's important. I'm going to skip this quickly, and then, okay, so this is very important too. And I mentioned this, is that there are some people who will have perfusion delays that are less than 6 seconds, even though less than 6 seconds is the standard. And this is very important, and that's why, not everything is radiology and computers. You always have to be, a doctor and know the clinical history and the story. And so here's an example. Here's a patient who has right arm weakness, mild aphasia, but they have a left M1 MCA occlusion. So they're having a stroke, okay? But then you look at this and you see nothing. You're like, what? What's happening? Okay, but if you look here, you see some blue. And more importantly, if you look here, you definitely see that the left and the right are not the same. So this is your perfusion. This is your penumbra in this case, okay? So whether these abnormalities are artifact, error, physiologic, or real, all depends on the clinical story. So in this case, that they have a right MCA syndrome. They have an M1 MCA occlusion. This just began a few hours ago. Yes, it's true. You see nothing here. That's surprising. Most of the time that won't happen. But sure enough, if you look here, something is wrong. So it's important to be aware that there are people who are going to be like that. Okay, and then a few other things. This is kind of the opposite. What do people look like who have an asymptomatic ICA occlusion? Okay, so they come into the ER, they had a right ICA that occluded 20 years ago. They don't have any stroke. They have like a Bell's palsy or something, and then someone orders a rapid. They shouldn't, but they do. Well, if you have an ICA or even chronic M1 occlusion, remember, blood cannot go in the forwards way. So they are going to be relying on their reversed collateral circulation forever, the rest of their life. So this patient may not have any symptoms, but they will have this very scary looking Tmax delay if you inject a bolus for the rest of their life. But that doesn't mean they're having an acute stroke. And the way you know is just clinical. Either you have symptoms that match this, like you're weak on the left and you're neglecting, or you're just sitting there, you're talking to everybody and there's no problem, and you have a headache or a tingling on your lips or something, or migraine. And then that's the pattern that suggests that this occlusion is chronic. But this will always be here for those chronic people, even though they're not having a stroke, and it will look just like an acute stroke. The most important thing is clinical, but there are some radiological clues. So you might notice that the Tmax is delayed, but you don't really see much there's no core, there's no mean transit time delay. And so that's the pattern of a chronic occlusion, is you see a big Tmax delay, but you don't really see very much anything else. Yeah. Similarly, here's this chronic occlusion. You see there's a big delay, left MCA. But then MTT, CBV, CBF, basically normal. Then here's the acute occlusion. You see a big delay here, Tmax, and then it's repeated on the MTT, and then it's repeated. You have the anterior part, you have a big blue, core here and core here. This is much more suggestive of an acute occlusion. So again, the most important thing is the clinical story. Either you have symptoms or you don't, but there are some radiological cues also. So that's important, because I definitely had radiologists call me and they're like, oh, this guy is having an acute stroke, oh my God. And you're like, no, they're not. They're fine. That happened 20 years ago. Don't worry about it. This is nothing. Yeah. So right. So that's important. And then, oh yeah. Question? Yeah. Yeah. Yes, you could see delay. Yes, definitely. So a great question. So if they have a carotid stenosis that's not symptomatic, then it's just medical management, or refer to vascular surgery for possible asymptomatic endarterectomy later in a week or something, but nothing acute to do. If you see a tight stenosis but a Tmax delay, and they have no symptoms, you could watch them for a day or something, but you're not going to go in there and put in a stent or do anything crazy like that because they have no symptoms. That's it. It's incidental. Yeah. Yeah. Endarterectomy? No, no, no. Yeah, no, 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 no. For endarterectomy, no. We don't really know the value of that. I think uh, uh, basically, if you have a symptomatic carotid stenosis, then and with a small stroke, you should have an endarterectomy within 10 to 14 days. If you have forgetting about perfusion, if you have a tight stenosis, if you have tight stenosis and you have no symptoms, it's very controversial what you should do. A lot of people here now would just say Lipitor, 80 milligrams, aspirin, blood pressure, stop smoking. That's it. Don't do any surgery. Other people would say, well, we can do surgery, but the risk benefit is much less than you would think. So controversial for people who have no symptoms at all. Yeah, but we don't make decisions based on perfusion because it doesn't tell you anything. You could have a horrible perfusion defect but be fine for the rest of your life. Yeah. Yeah. Okay. So again, this is really important. So what this is, you can see how bad this is, right? Because this is extended. These curves are not sharp, and they don't have a trough. This is the perfect person. You don't have to be this perfect, but this is what you want to aim for. That kind of thing. Similarly, this is what terrible motion looks. This is the horrible. The patient was moving all over, and then this is what you want. So this is the perfect patient. So you don't have to be this good, but you want to get something like this, okay, to get a good scan. So that's important. And then these are just various kinds of artifacts. You don't want to spend too much time on this. The point is that all of these look bad. The one important thing is that patients who have very poor cardiac output, like ejection fraction of 10%, even if nothing went wrong with the scan, they may look like this. The bolus will come in late and they will have rolling kills instead of sharp peaks. And that's just because their blood flow is bad. And unfortunately, we don't really know how to interpret CT perfusion in that case. It's better to use MRI in that situation. So if you have a patient with very bad cardiac output like EF of 10 to 15%, you should know that CT perfusion may not give you accurate results. So that's important. The rest of this is all just silly, like, patient was moving and the IV fell out and, it all looks terrible. But this is an important one. Okay, and then another thing, head position, always important, and then no motion. Okay, and then this, I think, is relevant to the example you showed me. So when should you suspect that you have a bad scan? So whenever you see colors that are on both sides of the brain or covering the whole brain or non-vascular, you should think, this might be a bad scan. Especially if you see green everywhere, like the scan you showed me, that's 100% artifact almost. So if you see everything green, then it's going to be bad. And you see there's a little warning. It says review source data quality, but sometimes you will have a case like this that is in between, because you could say, maybe they threw two emboli. Maybe they have AFib and they threw a clot here and they threw a clot here. It's possible. Or maybe they have a chronic stenosis here and they have a new stroke here. So how do you tell? Well, hopefully before you went here, you first went here, and then you can see this is a disaster. So you look at this first and you say, this scan is bad because this curve is horrible. And then you look at this and you say, I don't know what this means. This is just garbage. Yeah, so maybe they're having a stroke. I don't know, maybe they're not. So what you have to do is redo the scan with a better curve and then come back and look at the second one. Yeah. So always look at this first, and then that will make this stuff much less confusing. Does that make sense? Okay, good, great. And then Yeah, that's actually basically it. I just wanted to show you some of the, some of the things that can be confusing about Rapid, but they're not that many, and you guys are very smart and sophisticated, so I think you'll get that. But yeah, those are the few things where people can get a little bit confused, but that's it. Mhm. Any questions? Okay. Okay. Very good. Thank you so much for the questions. That's excellent. And so the other three modules are much smaller, much easier. We could do all of those quickly, like in 45 minutes. And I think we'll probably schedule a separate time for that. But if you have any further questions in the meantime, or if you have, you can always email us. And also, if you have cases, like anytime, for the next like 50 years, if you have a case or cases that you don't like, you just email them to us free of charge and we will review them and get back to you. So you can always do that. Mhm. I'm sorry? Oh, the email. Yeah, yeah. So Dana can tell you like what the support line is. She can give you the email, like
Yes.
how you would contact us. Yeah, yeah. She'll
Yeah.
tell you all about that. Yeah, yeah,
Yeah.
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 And I just learned from, yeah. So just a quick question about whether we should keep going for this training, or we should schedule for another time for the training.
Yeah, it's up to, I mean, it's going to be like another 45. I think people might start falling asleep and stuff.
Yeah.
Một điều nữa một yêu quên hỏi em một câu là vừa nói là cái thời gian động mạch không đến trước 10 giây và tĩnh mạch thì không thải đến trước 30 giây, là thải trước 30 giây đúng không? Mình hiểu là 5 giây. Đấy này thì nghĩa là không được đến sớm trước 5 giây đúng không? Tĩnh mạch thì không trước 30 giây à? Anh hỏi em xem là cái việc mà mình thay đổi cái tốc độ tiêm cũng như là lượng thuốc tiêm và cái nồng độ thuốc tiêm ấy thì nó có việc thay đổi, nó sẽ làm thay đổi cái thời gian thuốc đến sớm hơn hoặc muộn hơn này, thì điều đấy thì cái đấy có còn đúng không, với mình tiêm với tốc độ khác nhau? Khi mình tiêm tốc độ lớn hơn thì có thể là hoặc thuốc là độ cao nhưng nó sẽ trung bình cái thời điểm đạt đỉnh cũng như là cái biểu đồ nó sẽ đến sớm hơn về mặt thời gian ấy, nó đương nhiên sớm hơn thì nó sẽ giải thuốc nhanh hơn.
Mhm. Do I have time? Yeah, sure. I mean, I can keep going. I just want to make sure you guys are okay. I mean, I'm happy
Yeah.
to. You sure? Oh, okay. Yes, yes, yes. Go ahead. Mhm. Yeah. The volume acquisition? Oh, the rate of the injection, the rate of the injection. Yes, yes, yes. Yeah, so I don't actually know the specific parameters, but we have, Dana will be able to give you all of that for the technical parameters on how fast you should inject. You don't have to be perfect, but I actually don't know exactly what it is. Yeah, I know it's 40 cc's. I don't remember the rate is pretty quick, but she will have all the technical engineering. She can give you all of that to the technicians. Yeah, and the technicians should get their separate training also, by the way, completely separate. Mhm.
Yes.
Yeah, yeah, yeah.
Yes, if you like to call it a stop here, then we can schedule another training for the CTA and the remaining aspects and ISH, which can be very short. So as Dr. Calamity just said, that will be around 45 minutes. So that will be the part 2 clinical training. And as for the injection, we can schedule another technical training for the technicians, if you like. Yeah.
Xin từ đầu rồi nói từ đầu rồi. Khi nào nó
Yes.
Yes, I think we did good with CT perfusion. Yeah, that was, no, you guys were great. Thank you.
Yeah, I know, because it's lunchtime. Sorry for that.
Yeah, you need to get lunch. But yeah, this is the biggest one. The other ones are much quicker, easier.
Yes.
Yeah. Mm-hmm. No, it's great. No. It was a pleasure. I really enjoy it. It's actually my usual United States one. People don't even ask questions. So actually, I enjoy this more. So this is great.
Yeah, more interactions with the doctors.
Oh, I'd love to. Yeah, please. I'd love to speak as many times as you want. So thank you so much. Good luck to you. Okay.
Okay, thank you, Dr. Kananati.
Okay.
So I'll keep you informed of the time.
Okay. Thanks,
Yeah.
Anna. You take care.
Thanks.
Bye.
Yeah, you too.
Yep.
Thank you.
Sure. Yep.
Bye.